Critical Thinking and Coding Tips for Chapter 17. Now our first critical thinking question: how is a GI bleed coded? And our answer: when coding a GI bleed, research the record to find the cause of the GI bleed. Sometimes the cause is not identified, and therefore the principal diagnosis would be the GI bleed code itself, which is 578.X. Often there is one code to identify a condition with a GI bleed. Some of these conditions include ulcer of the esophagus with bleeding, which is 530.21, and diverticulosis of colon with hemorrhage, which is 562.12. Now, other situations indicate that more than one code might be necessary to identify both the cause of the bleed and the fact that the patient did not indeed have a GI bleed. One example of this is a patient who is admitted with a GI bleed and the cause is determined to be a colon polyp. First, the coder needs to determine whether the GI bleed is an integral part of the polyp. Does it always occur with this condition? Examples are abdominal pain and cholecystitis. The abdominal pain would not be coded because it is integral to the disease process. Now, because a GI bleed is not integral to a colon polyp, 211.3 would be coded as the principal diagnosis, in addition to 578.9 for the GI bleed to provide further detail that the polyp was accompanied by a GI bleed. Now our next question: how is a bowel obstruction coded, and what if the cause or type is documented? And our answer: a bowel obstruction of unknown etiology is coded as 560.9, unspecified intestinal obstruction. If the cause or type is known, there is often a combination code to describe the obstruction and the cause or type. Now examples would include the following, which would be bowel obstruction due to adhesions, 560.81, a volvulus, which is 560.2, a bowel obstruction due to fecal impaction, which is 560.39, and an ileus, which is 560.1. If the obstruction is due to external compression, code the etiology first, such as Crohn's disease or metastasis of cancer, etc. Now examples. A patient is admitted for bowel obstruction due to Crohn's disease. Assign code 555.9 as principal for the Crohn's disease and 560.89 as an additional code, which is for the bowel obstruction. Obstructions are common with Crohn's disease. However, not every patient with Crohn's disease develops obstruction. So in this case, obstructions are not integral to Crohn's disease, and therefore the obstruction can be added as a secondary diagnosis. Next example. A patient is admitted with an SBO, which is small bowel obstruction, secondary to metastatic abdominal carcinomatosis. Assign code 197.6 as the principal, which is the metastatic abdominal carcinomatosis, and 199.1 as secondary for unknown principal site, and 560.89 as another secondary diagnosis for the small bowel obstruction. Because the cause of the obstruction is known, which is the carcinomatosis, that is sequenced as principal. Okay, our last question. What is the correct sequencing of cirrhosis and/or hepatic encephalopathy and cirrhosis and/or hepatitis and/or varices? Our answer is, in the case of a patient who is admitted with hepatic encephalopathy and cirrhosis, assign the hepatic encephalopathy and/or coma, which is 572.2 as the principal diagnosis, with the cirrhosis code as an additional diagnosis. Hepatic encephalopathy is a life-threatening event that requires immediate intervention and treatment. Treatment is for the infection or alcoholism that caused the encephalopathy, whereas the cirrhosis would not itself be treated. as there really is no treatment for cirrhosis. Now, the same is true for varices associated with a liver disorder, such as hepatitis and/or cirrhosis. The underlying disease is coded first, as stated in the code description, code first underlying disease, followed by the varices code as a secondary diagnosis. This is true even if the treatment is aimed at the varices. The varices cannot be coded as the principal diagnosis based on the code first guidelines. Okay, we'll now discuss some coding tips for this chapter. A hernia that is documented as incarcerated or strangulated is coded as with obstruction or obstructed. They can also be categorized as reducible or irreducible. Some hernia repairs are done with mesh to strengthen the walls of the organ or tissue where the protrusion has occurred, which is also considered to be a prosthesis or graft material. Don't forget to verify the codes in the tabular list and review all instructional notes. Next, coding AVMs, arteriovenous malformations of the GI tract. A common error that coders make is to code this particular condition to a congenital condition because of the term malformation. In the disease index, it cross-references "see also" to an anomaly. This would give you the code of 747.61. Most times these conditions are not congenital unless documented as such and should be coded to 569 or 537 category depending on the site. Next, coding liver failure status post acetaminophen overdose. A patient will often present to the emergency room with an acetaminophen overdose and then be admitted as an inpatient for liver failure. The MD will document liver failure due to the overdose throughout the record. However, it's important to remember that the poisoning guidelines will take precedence in this situation. Although the liver failure would appear to be the reason for the admission, the overdose would be sequenced as the principal diagnosis on the basis of poisoning guidelines, with the liver failure coded as an additional diagnosis. Okay, next, the coding of GI bleeds. It's not only important to try to find the cause of the GI bleed in the documentation, but it's also important to look for any complications that might accompany the GI bleed. One of the most common complications that follow a GI bleed is anemia. Anemia can be acute following a current acute onset of a massive GI bleed, or chronic due to a GI bleed that has lingered for many weeks or months due to various numbers of or conditions. Both of these anemia codes, 285.1 acute post-hemorrhagic anemia and 280.0 anemia secondary to blood loss, are complications and/or comorbidities that can affect the MSDRG and therefore optimize a case. Now, however, it's important to remember that the physician must document the anemia in order for it to be coded. If there are signs and/or symptoms and/or laboratory findings and/or treatments that indicate that anemia is present, but the physician does not document it in the record, it's appropriate for the coder to query the physician. Look for these items that might accompany a GI bleed that could indicate anemia. There would be weakness, low hemoglobin and/or hematocrit, and patient received iron and/or a blood transfusion. Okay, what is Helicobacter pylori, or H. pylori, and how is it coded? H. pylori is often seen with peptic ulcers, which are ulcers of the esophagus, stomach, duodenum, jejunum, and gastrojejunal, and the ileum. An esophageal gastroduodenoscopy, or EGD, is performed and a biopsy is done to determine whether the ulcer has the H. pylori infection. The pathology report will confirm or deny the presence of the H. pylori infection. The coder should sequence the peptic ulcer code first, followed by 041.86 to show that the H. pylori was the infection causing the ulcer. Next, the use of the codes for a laparoscopic surgical procedure converted to an open procedure. Now, coders must be aware that these particular V codes because they are not diagnosis codes and can often be overlooked. The code of V64.4X can be used for other, such as a scope procedure, that were converted to an open, such as arthroscopic and thoracoscopic. These V codes are to be used only as a secondary diagnosis. Next, coding ventral hernias. A ventral hernia, NOS 553.20, is a hernia of the abdominal wall. It's important to review the record to see if the physician documents any term that might be more precise and therefore changes the diagnosis code. If the hernia is obstructed or has gangrene, the code could change. Sometimes this is noted only in the body of the operative report. If the ventral hernia is at a previous surgical site, the hernia is then an incisional hernia, and again the code would change. Okay, now we're going to discuss EGD and colonoscopies. EGD, which is an esophageal gastroduodenoscopy, is a diagnostic procedure used to inspect the esophagus, stomach, and duodenum via an endoscope. Other procedures that may accompany an EGD include biopsy, excision of a lesion, control of bleeding, and dilation of a stricture. Physicians often refer to this procedure as an upper endoscopy. It's important to review the operative record to see exactly how far the scope was done. In some instances, the physician may only perform an esophagoscopy, or perhaps only as far as the stomach. Be sure that the procedure code used identifies to what extent the scope was done. Next, a colonoscopy is an examination of the upper portion of the rectum into the large intestine with an elongated speculum or a coloscope. It too can be accompanied by a biopsy, excision or destruction of the lesion, control of bleeding, or dilation. Once again, review the operative record to see exactly what procedure was performed, such as diagnostic and/or therapeutic. Physicians refer to this procedure as a lower endoscopy. Okay, now coding gastroenteritis and dehydration. Determination of what diagnosis should be sequenced as principal diagnosis depends on the circumstances of the admission. Which diagnosis meets the definition of principal diagnosis? In some instances, they may both meet the definition, and therefore the case should be optimized, and either can be sequenced first, choosing the code that would have the higher MSDRG. Okay, we're going to end our coding tips with a couple of reviews. A patient is admitted with nausea, vomiting, and diarrhea consistent with Clostridium difficile, which is a positive stool culture. The patient is given IV antibiotics and IV fluid hydration. Now, in this case, the infectious gastroenteritis, or code 008.45, would be sequenced as the principal code, and dehydration sequenced as an additional code. Now, here's a coding clinic question from August 1984, which further addresses this issue. When a patient is admitted for dehydration due to a bout of gastroenteritis, is the principal diagnosis dehydration if IV fluids are administered for rehydration? The MD contends that the patient was admitted for the treatment of dehydration resulting from gastroenteritis. The patient would not have been admitted for treatment of the non-infectious gastroenteritis. Now the answer, the physician sequencing is correct. The condition that necessitated the admission is the dehydration for rehydration therapy. Gastroenteritis would be sequenced second position to show the underlying condition that may not have necessitated inpatient treatment. See Coding Clinic, second quarter, 1988, pages 9 through 11 for more examples.